Assalamu alaikum, sabah al-khair. Thank you so much for coming on a Friday morning. It's usually a time for sleep. I'd like to say that my lecture cannot be given in half an hour. To talk about research, you need days. There are courses for research. But I'd like to touch on the most important points that one has to keep in mind. And also, I give you an example or two of simple research that we have done that you could possibly start with. Research can be very difficult if you're talking about multi-central, double-blind, crossover studies, but it can also be made simpler and a start for your publication. Publications are now becoming very important in anybody's CV. It's almost mandatory to be accepted at a fellow above to have some research background and some publications, okay? So that's why I started with research made easy. And it's not easy, but we can try and make it easier. And I'll talk about the principles of medical and clinical research. What's the difference between medical research and clinical research? Okay, clinical research is basically research on patients. Medical research includes research in animals, research on laboratory research. All this is called medical research. Clinical research suggests using patients, treating patients, studying patients, clinical research. That's why I put medical, which is the wider, and clinical research between quotations. I have nothing to declare. I have no conflict of interest with research. The question is, why do we do research? I mean, this question arises in anybody's mind as you climb the ladder. Why do we do research? There are many, many reasons to do research. I just summarize a few here. Obviously, everybody wants to improve patients' care. And patients' care can only be improved if there is a clear evidence, not speculation. So we do research to prove or disprove what we think. The other thing is, it's very important for your professional development, for your CV. It's for publications and to be recognized in your field. It also, research improves your critical thinking. The way you think about things, if you do research, is very different if you don't do research. Critical thinking. It develops your analysis of data and also problem solving in clinical practice. You want to contribute to medical knowledge. You want to have your name in the medical literature. It's very nice to put your in search and find your name is there. You have put a landmark in the field of medicine. Finally, many hospitals now, many universities, to be promoted, and in fact, even to renew contract, you have to have CMEs and CPDs. I'm still required to produce 40 CPDs a year. 80, 40 category A and 40 category 1 and 40 category 2, 3. Yeah? This would be considered a category 1. I'm sure you recognize these Akakis pictures. Akakis is one of the UNESCO 5 sites in Libya which are recognized. It's not the Akakis mountains that are recognized by the UNESCO. It's the Akakis drawings, which are about 5,000 years plus. It's one of the oldest in the world. This is hunting. You can see the man here and his dogs hunting these buffaloes, I think. Okay, when you do research, the first thing is the question, or we call it the hypothesis. That's the first thing you have in research. You have a question and you want an answer. Then you go about how you get that answer. Why is the hypothesis and the question is important? Because not all good ideas are good clinical practice. You may have an idea, it sounds fantastic, but when you put it to research, it turns to be a very bad thing. I'll give you an example from the literature. I'm sure you all know about the CAS trial. The CAS trial, the cardiac arrhythmia suppression trial. The cardiac suppression trial had the question, the hypothesis. After myocardial infarction, many patients have PVCs, and some of them have high PVCs. So the idea was, if we suppress the PVCs, maybe we will reduce sudden cardiac death. That was the hypothesis. It sounds fantastic. So they started giving them medications, flecainide, eucainide, and others, and this was a controlled trial against placebo. Placebo means the tablet looks the same, but it doesn't contain anything. It's just starch. And the study, as I say, the question was, does the suppression of ventricular ectopy after myocardial infarction reduce the incidence of sudden cardiac death? You would think it does. If you reduce PVCs, you should improve survival. But CAST trials showed that if you give these patients medications, you suppress the PVCs, but you actually increase the mortality. And here is the graph in 500 days. By the way, this is a survival graph. So the lower means higher mortality, not higher survival. I think these should be called mortality curves. In patients who have received placebo, the survival of 5 years is much better than those who have received the treatment. And the difference is 3.6 times fold. More mortality in patients who took medications. Even though when you did the Holter, the PVCs are less. So not all good ideas are good results. Yeah? And that's one of the reasons we do research. Yeah? And CAST trial, the cardiac arrhythmia suppression trial, is one of the best examples. And the conclusion of that study was there was an excess of deaths due to arrhythmia and deaths due to shock in the treated group with eucainide and flecainide. And the mechanism of why this increased death is subject to speculations, but the core message is suppression with these medications increase mortalities. Before you do research, there are a few things you need to think about. Think, if you have an idea, is this question really needed? Or has it already been answered? Don't repeat other people's research, just want to repeat, except under one condition. If you are testing a distinctly different population. For example, we know that calcium antagonists work very well in whites, but they work very bad in black people. So if you want to do the study in black people versus white people, okay. But to repeat, just to repeat, try and avoid just repeating. And unless, as I say, you have a good question. Find a good idea, find it relevant, even if the idea is simple, and I'll give you a couple of examples. And as I said, find a question that has not been answered or still being debated. Then ask yourself, can I means my group, can we do it? Is it feasible? Do we have the manpower? Do we have enough patients? Do we have the tests in the lab? Do I have the fund? Ask, can it be done? And find out who else be interested in your department, in your area. There may be somebody interested in في الطبي, the other one في الخضراء. Make a research group and try and get together and study the question. As I said, ask the question, has it been done? Don't just repeat. And very important is once you think of an idea and you decide this may be a subject of research, do good literature research. One of the reasons we do literature research, sometimes you start with an idea and yet, as you do the literature research, you find that, oh, maybe you can do it this way better. You understand? You learn from the literature research and you improve your idea. And I'll give you here a couple of examples from our own research, which we've done in the Heart Center. A couple of fellows came to me and said, well, we want to do research. We sat together and we decided a couple of very simple ideas and we got them published. You can do it yourself. What is the first idea? The first idea is we looked at patients who came in with acute coronary syndrome to see how many of them are diabetic and they don't know. How many of them have glucose intolerance and they don't know. These are patients admitted with acute coronary syndrome. They don't know they are diabetic. They're not on diabetic medications. All right? So the title of the research is Prevalence of Unrecognized Diabetes in Patients with acute coronary syndrome. I can't remember the journal we published it in. Okay, what we did a prospective study. We recruited about 600 patients, and we went on to look at the hemoglobin A1C, and some of them we have done glucose tolerance tests according to the guidelines for the diagnosis of diabetes. And you'll be shocked that 21% of patients admitted with acute coronary syndrome who did not know the diabetics, 21% were frank diabetics by definition of international guidelines. 21%. A further 14% were pre-diabetes, and about 10% roughly had stress hyperglycemia because on follow-up they normalized completely. All right? So if you add all these together, 55% of patients with acute coronary syndrome were either diabetics, pre-diabetics, or had stress hyperglycemia. This shows you how much undiscovered diabetes there is in the community. Yeah? We did another study, very similar. We looked at, this is another group, another hospital, the same thing, the fellows came. I said, oh, those guys done that, why don't we do something else? We looked at the prevalence of metabolic syndrome components, you know the components of metabolic syndrome, the waist circumference, the weight, the BMI and all that, the blood pressure, the triglycerides. And we looked at the prevalence of all these components separate or in combination in patients who had or who were admitted with acute coronary syndrome. Yeah? So in this here, we have about 500 patients, and we found that nearly 70% of them had at least one criterion of metabolic syndrome, and about 1/3 of them had 2 or 3 components of metabolic syndrome. This is clear metabolic syndrome. And the conclusion is that patients without diabetes, by the way, without previous history of diabetes, metabolic syndrome is very highly prevalent, especially reduced HDL with elevated glucose, with elevated triglycerides. Are these the most frequent? Majority had multiple components. These findings raise alarm. This is the relevant. These findings raise alarm and show that drug therapy alone may not be fully effective in patients with coronary artery disease. Because if you give them medications, you reduce these triglycerides, you reduce this, you reduce that, but they're still metabolic syndrome. So drugs alone are not effective. Okay, what are the types of research design? We will only go for revision. This is only a revision. We talk about retrospective studies and prospective studies. This is the big titles. And the difference between the prospective and retrospective is very obvious. The timing, prospective look forward, retrospective look backwards. The data collection, obviously, prospective is real time. You collect data as you go on. And the retrospective, the data is already existing. So for retrospective, it's very important that you have some form of database in your hospital, or you start collecting from now every patient who is admitted with admitted for heart failure, for acute coronary syndrome, for arrhythmia, for atrial fibrillation. Make sure you collect as much data, every patient. And you'll be so surprised that after 5 years, you have enough data to publish. Yeah? The technical stuff. بعدين I just want to make sure that we don't run out. Yeah. So this is for retrospective study. Prospective studies are obviously much more costly than retrospective studies. But they are much more reliable, they are more robust. So get your group, start now. Build up your database. But please, from beginning, in the database, try to include everything you can that's relevant. Because if you forget something, and after 2 years you add it, Then you have 2 years of patients who have the data, and 3 years they don't have the data. And then it becomes difficult to compare. Okay, we'll start now. We talked about retrospective studies. Let's talk about the prospective studies. Prospective studies are generally divided into studies, which are non-interventional, and trials, which are interventional. Whether it's the intervention is coronary intervention, device intervention, drug intervention, or even preventative interventions. You know, like the US study where reducing cholesterol, trying to see what So intervention does not mean only giving medication, doing a procedure, or implanting a device. Yeah. So these are intervention. We call them trials. The non-intervention, we call them studies, conventionally. When it comes to observational studies in a perspective, you could do cross-section. Now, I'll get all the people who come to معرض طرابلس مثلا, and I'll take their blood pressure, I'll take their blood sugar, Okay? Now, you will get a mix of people. You get elderly people, you get children, you got that. So you can make an overall analysis, but I think it's important that you categorize. But because what the blood pressure relevant for an elderly is not the blood pressure relevant for a child. You cannot say, oh, the average blood pressure of my 1,000 population is 130/90, when half of them are children under the age of 12. Yeah? So it's very important. Averages have to be taken in the context. Longitudinal studies, there are huge databases like Framingham study, which is going for many years and got millions of patients and is producing brilliant results every year. Okay. Okay, when we come to interventional studies, there are some categories. Randomized are better than non-randomized. Controlled are better than non-controlled. Placebo-controlled are better. And crossover studies we'll come and talk about in a minute. In uncontrolled trial, one group you treat, and that's it. So usually it's before, after. Before the treatment, their cholesterol and so on. So after treatment, it's one group, it's controlled, it's very easy to do. But this is not the best, obviously. Controlled, there could be 2 drugs, there could be 3 drugs, there could be a drug and placebo, and so on. So when you come to controlled studies, there's the open label, which means everybody knows the tablet. They know this is ACE inhibitor. Yeah? This is open label. There is single blind and double blind studies. Single blind means only the patient doesn't know. Double blind means the patient and the treating physician don't know. But in these, it's very important that you have a quick access to disclose. Because if a person, one of the patients, is taking a medication and he has severe allergy, you need to know quickly, is he in the placebo group, or is he taking drug A or B or C? So if you have double blind, it's very important that you have quick access, somebody authorized to have a quick access to open. And only under these circumstances, otherwise you don't open the double blind. We talked about group control, placebo controlled. In one arm there's placebo and the other is the drug, and the crossover studies. So this is it, basically, randomized versus randomized. Randomized is better. Blinded is better than open label. Double blind is better than single blind. Controlled trials are better than controlled trials. And the crossover studies. This is a single blind or double blind? Single blind. The big cat knows where they're going. The little one has no idea where they're going. So this is a single blind study. Okay, I just want to spend a couple of minutes on crossover studies. Crossover studies are very robust studies, but they need a lot of arrangements because all the studies we talked about so far, we call parallel studies. Control, uncontrolled, placebo, and all that. Parallel. You have 2 groups or 3 groups, and they're parallel at the same time. In crossover studies, what you'll do is you have a group A, for example, is taking placebo. It'll be placebo cross trial. Or group A is taking one drug and group B is taking another drug. Then, after a period of time, weeks usually, depending on the effect of medication and pharmacodynamics, you swap. Those who are taking drug A will take B, and those who are taking B will take A. But before you do the swap, you must do something. What is it you should do before you swap? Sorry? Wash up. Yes. Wash out period. It's very important that before you swap, you do wash out period. Because otherwise there'll be some effect left from drug A and some effect from drug B. Okay? So you cross over. Is it always possible to do crossover studies? Is it always possible to do crossover studies? No. Because, for example, let's say we have two groups of patients, like we'll come to MADIT trial. One group have taking medication, the other one has an ICD. You cannot say, okay, now we'll take your ICD out and we'll put it in the other guy. You can't do that. And for example, if you do intervention, if you do, for example, comparing thrombolysis with primary PCI in acute, you cannot do crossover. But after you do it, say, okay, we'll take your stent out and give you thrombolysis, and you will give you understand? So not all studies, not all ideas are applicable to crossover studies, okay? Especially where there's intervention or devices, it's not applicable. We'll touch now on a little bit on statistical analysis. Okay, how do we do statistical analysis? The first thing you have to ask yourself is, obviously, do I have enough data? Assume that we already have enough data, you have enough numbers in the groups you study, whether it's single group or multiple groups. And then ask yourself, is my data a numerical variable? Am I collecting numerical variables, 1, 2, 3, blood pressure of 120, 30, 40, 60? Or is it categorical, diabetic or non-diabetic, pregnant or not pregnant? These are called categorical. The first one is numerical. So is it numerical variable or a categorical variable? And the second question is, how many variables I have? Do I have 1, 2, 3, 4? For example, I have a study of 3 groups. Hypertensive patients. One, I'm giving them only non-interventional, means losing weight, The other one, I'm giving ACE inhibitors. The other one is giving beta blockers, just for argument's sake. Okay, so we have three groups. How many groups? Or 2 groups, or 4 groups. Usually it's 1, 2, or 3. Most studies are within that period. Okay, numerical variables, as I say, are a continuous variable. This is the other name for it. 1, 2, 3, 4, 5, 1.6, 1.8, 120, height, age, blood pressure, heart rate, blood sugar. These are all numerical variables, numbers. Categorical variables are diabetic, non-diabetic, male, female, pregnant, not pregnant. Yes? These are the MI, no myocardial infarction. Okay, let's start with analysis of when we have 2 groups of numerical variables. And the simplest test we use in these is the t-test, yeah? The t-student test. And here's an example. We have to make it simple, we have 2 groups. In group 1, this is the heart rate. In group 2, these are the heart rates. And at the bottom, we have the mean, yeah? We want to know, is the difference between these 2 groups significant or not? We use the t-table or t-student test. You know why it's called student test? Do you know why it's called student test? Yeah, it's not discovered by students. It's called student test. This guy, he's a statistician in Ireland, and he worked for a company, a big company, that does statistical analysis for big research. And he has invented the t-test, but he was not allowed by the company to publish it under his own name. He has to publish it either under the company name or a fake name. So he chose student. All his publications, student. It's published by a student. That's why it's called student. But his name is Albier something. Okay. So here we have the two means. You need to find the standard deviation, and then you can do the t-test, and you get the result. Is this significant or not significant? Okay, well, how about if we have more than two? We have 3 groups or 4 groups. T-test will not apply. The only thing is, t-test, for example, you have 3 groups. You can compare group 1 with 2 with the t-test, 2 with 3 with the t-test, 1 with 3 with the t-test. This is unreliable, unless you want to do specific analysis between the 2 groups. I want to know the difference, significance between group 1 and group 3. But if you want to get the overall result, you have to apply another test called analysis of variance, ANOVA. The ANOVA test, the same thing here, group 1, group 2, group 3. We have the means. We will get the standard deviation of each group, and the test that we should apply is called analysis of variance or ANOVA test. ANOVA test is a kind of modification of a t-test. Yeah? Incidentally, if you apply ANOVA test to 2 groups, you get the same result as a t-test for the 2 groups. Yeah? So if you don't want to bother learning about the t-test, just learn the ANOVA test. And 2 groups, you can do it. 3 groups, you can do it. 4 groups, you can do it. Yeah? ANOVA, analysis of variance. Very important test. Incidentally, ANOVA is different to multivariate analysis test. There's another test called multivariate analysis test used for analysis of multiple groups. It's more powerful than ANOVA test. But this is a simple one. And incidentally, there's an application. You don't have to do your calculation, standard deviation, or the under square, I don't know what. You don't need to do that. You can go ANOVA test, put your data, you get the means, bang, you get the p-value. That's it. So you have the total number of patients, you have the mean, you have the standard deviation, and you have the significance level. Yeah? It's ANOVA test. Analysis of variance. Okay. Where is this?
صبرات.
ها؟
صبرات.
لا. ولا لبدة. شحات. This is Corena شحات. This is شحات. ها؟
تشبه صبرات.
إيه تشبه صبراتة بس شحات. Okay. Now let's suppose we have categorical variables. What did we say categorical variables like? Male, female. Diabetic, not diabetic. Pregnant, not pregnant. Myocardial infarction, not myocardial infarction. Anemia, no anemia. Now, anemia can be a categorical variable, and it can be a numerical variable. If you look at the hemoglobin 9.2, 10.7, 11.3, then it becomes numerical variable. But if you put a cutoff, 10 milligrams, 10 grams percent above not diabetic, below above not anemic, below not anemic, then it becomes categorical variable. Yeah. So there are some variables you can make them categorical, and in your publication you can analyze it both ways, and that will add strength to your publication. So you say, okay, we analyzed it numerically, we got this finding, and we analyzed it according to categories, and we found that the same significance. Okay? So there are numerical variables, the categorical variables. There are numerical variables can also be made categorical variables. All right. For categorical variable, the simple test of choice is the chi-square test. yeah, the chi-square test. And here's an example. If we looked, for example, in our study that I showed you earlier, you know, unrecognized diabetes and acute coronary syndrome, we used this test. Here, we looked at patients who were admitted. How many of them had acute myocardial infarction? I'm sorry, I'll go to the screen. How many of them have acute myocardial infarction but not diabetic? So myocardial infarction, yes. Diabetes, no. And how many patients have acute myocardial infarction and were diabetic at the same time? Okay, you will get this data. It's very simple. Here, they're neither diabetic nor myocardial infarction. Here, myocardial infarction and diabetic. Okay? Here, myocardial infarction, but not diabetic. And so on. So this is categorical variables. All right? And the test of choice is the chi-square test. Okay, so to sum up, for numerical variables, 2 groups, t-test. More than 2 groups, analysis of variance. For categorical variables, the chi-square test. You can study numerical variables as well as categorical in the same group. As I say, for example, if you're collecting 2 patients, pregnant and non-pregnant, and you look at hemoglobin, 10, 11.7, you can analyze it as numerical, t-test. Or you can say, okay, at 10.5, above, not anemic, below anemic, then it becomes categorical variable. Okay? Okay. You've also heard that there are some studies which are stopped early. Why do you think studies are stopped early? Huh?
Make harm of the patient.
Okay, yes. If the intervention, being a device or medication, is causing harm, especially if it's causing excessive mortality. And before they start the study, they'll say, okay, if there's a mortality at 3 months of this much, the study has to be finished. This is very obvious, yeah? But there's another reason why studies can be stopped early.
Technical issue.
Huh?
Technical issue.
Yes, technical issue, lack of funds, patients are not consenting, no patient wants to come in. But there's another surprising reason. Sorry? Yes. If the benefit is so good, and it's statistically significant and fulfills all the criteria, it's not ethical to continue. I'll give you an example. I'm sure this one example here of how a study giving bad results is stopped. This is the study to raise HDL. You know, we have great drugs to reduce LDL, statins. They reduce LDL, they stabilize the endothelium, the pleiotropic effect, and so on. But so far, we don't have good, effective drugs to raise HDL. Nicotinic acid, but it's very unpleasant. Yeah? We don't have. There was a study, there was a couple of trials actually, on drugs which are very good in raising HDL. But 2 oral and 1 I think is parenteral. And I want to concentrate on this study here. In this study, the medication is used to increase HDL. It works on CATP inhibitors. And when they did the study, the HDL went up very nicely, the LDL went down very nicely, the ratio went up very nicely. The apolipoproteins also improved, but there was 20% increased mortality. And overall, there was 60% increase in events. It was a surprising finding, but you cannot continue a study like this because we're not treating the laboratory results, we're treating patients. I mean, technically, it's a very successful trial because the HDL is going up, the LDL is going down. But clinically, it's not ethical to continue. So this is one example of a study. In addition to, you remember to the CAS trial, the one I showed you at the beginning, the cardiac arrhythmia suppression trial with increased mortality of medication. This is another example of a study. However, as we said, that sometimes studies are stopped because the results are too good. And one of the very good examples is the MADA-2 trial. You remember MADA-1 trial was putting implantable defibrillators in patients who had myocardial infarction, low ejection fraction, and sudden cardiac death, or sustained ventricular arrhythmia, or EPS arrhythmia. And these patients received implantable defibrillators, and the results were very good. So people thought, oh, why don't we put ICD in patients who had myocardial infarction, low ejection fraction, but did not have cardiac arrest, resuscitated, they don't have sustained arrhythmia, and we don't do EPS study. Yeah, it's a daring study. And the two arms were, one arm is ICD, the other arm is best medical treatment. And these are the criteria: low ejection fraction, no history of sustained ventricular arrhythmia. They weren't randomized to. And when they looked interim analysis, they found big gap, significant gap. Patients who have received implantable defibrillators have better survival than the best medical therapy. So it became unethical to continue giving people medical therapy when we know ICD can save lives. So that's the MADA-2 trial was stopped early because of very good results. So please, from today, I want you to remember the CAS trial, the CAS arrhythmia trial. Sounds a good idea, but it turned out to be very bad. I want you to remember the HDL trial, where very good HDL results, but had mortality or higher events. I wanted to remember the MADA-2 trial. These are very classic discussion trials, very, very classic discussion trial. And you can see there the defibrillation, the survival is higher in the defibrillation than conventional therapy, and the p-value is highly significant. The analysis done here is multivariate analysis, okay? And the two, starting to part about 1 year, and at 2 years, it was very clear, okay? So the study was stopped because there was 30% better survival in the ICD group, and it was unethical to continue the trial. Okay, so in conclusion, my colleagues, research is an essential part of clinical excellence at all levels. In fact, I would encourage clinical research from medical school. Give people small project, not with the aim even of publication, for the exercise of research, yeah? Ask them, for example, to take the height and weight of the whole class, 100 people, and do mean blood pressure, do mean height, do mean height, weight, exercise how to do the t-test, analysis of variance test, simple test, categorical test. Divide them into, put, for example, a height of 160. Above 160 is tall, less than 160 is not tall. Yeah? That would be a categorical variable. Or take the heart rate, put heart rate of group 1, group 2, and do analysis. Not with the purpose of publication, but with the purpose of exercising research and getting into a research mind. Start very early. Not necessarily at the beginning for publication. Okay. Find out a good idea, do a literature search, think about the main question, formulate a hypothesis. You remember we went into the hypothesis from beginning. And then look at the study design. You want to do it observational study, cross-sectional study, prospective study, and so on. In the beginning, start with a retrospective study. If you don't have enough data, build your data in your department from now, okay? And finally, apply the correct statistical analysis that we have discussed. Derive the main conclusions. When you derive the main conclusion, please, we all like to prove something. but the study is proving something else. Don't twist and retwist the data and twist the statistical analysis and use the wrong statistical test to prove your point. هذا ما فيش أمانة العلمية. And somebody will prove you wrong. And it's not nice. Yeah? And finally, write your work as soon as possible. If you leave your work not to write it after 1 year, it becomes more difficult. 2 years, more difficult. So write it as soon as possible. Publish in a small journal. It doesn't have to be in BMJ. It doesn't have to be in the New England Journal of Medicine. Publish in, I don't know, the medical school if it has. Start beginning, no need to publish. Just exercise research. And later, publish small research and get bigger. Okay? Thank you so much.